to be here. I'm going to speak about the follow-up of patients after resection for lung cancer. So, as we know, surgery for lung cancer for most patients is the only realistic chance of cure. However, not all patients we operate on will be cured, and there is a significant risk down the line post-surgery that they can recur. And the risk to them of new malignancy is relatively high. The incidence of recurrence is about 10% over the early years, declining to about 2% thereafter. And the risk of new primaries in these patients is up to 6% and persists over time. And so we've always advocated follow-up, but historically, follow-up of lung cancer patients has been by history, examination, and chest X-ray. However, more recently, CT has come in to the guidelines for the follow-up of these patients. And yet we do not really know the role of that. Now, why has CT become attractive and come into the guidelines? Well, I think it's down to three reasons. First of all, I don't think anyone would argue that CT is more sensitive than chest X-ray in the detection of thoracic disease. That goes without saying. Secondly, the lung cancer screening trials, the NLST and the Nelson trial, have left us without doubt that screening for lung cancer saves lives. Now, if you take the post-lung cancer resection cohort, they, you could argue, are a super high-risk group for new primaries, because their risk of new primaries is up to 10 times higher than the lung cancer naive patients that we've just heard about. And so that's quite powerful when you might want to think about following these patients up. Of course, there's the added issue in these patients, though, of recurrence. And it might be that recurrence is the most dominant factor in their survival rather than their new primaries. But if you look at recurrence in these patients, you can see that it tends to occur early. So of the subset of people who will recur, 80% of them will recur in those first 2 years. And if you look at this study from Lille, there are a number of studies, including this one, that suggest that asymptomatic recurrence has a better outlook than symptomatic recurrence. So those studies show that your survival will be 2 to 3 times less with symptomatic recurrence than asymptomatic recurrence. And the survival here was 15 months versus 7 months. So those three things are quite powerful in thinking that maybe CT follow-up of lung cancer patients might improve survival. But what is the evidence for that? Well, there's a meta-analysis here of 9 studies looking at how patients were followed up. And this looked at a subgroup of radically treated patients who underwent intensive and non-intensive follow-up. And there was a trend here towards increased survival with intensive follow-up programs, a hazard ratio of 0.6. If you look again at the symptomatic versus the asymptomatic, this was statistically significant improved survival. So CT has found its way into the guidelines, and all of the makers of the guidelines, if they do mention an imaging modality, and not all of them do, suggest that it should be CT. But whether it should be CT chest, IV contrast CT chest, abdomen, pelvis, the interval, who should do it, they all vary. And so probably all of us who are following up lung cancer patients could find a guideline that would match what we were doing. But what does the evidence show? What does the better evidence show? This is a study from Toronto, which is a higher level of evidence, that took patients, 331 patients over 5 years, into a CT follow-up program and a chest X-ray program. So they got chest X-ray and they got CT over time, and they compared the outcomes. And what they found there was that CT was more sensitive, 94% compared to 21%. And it had a higher negative predictive value, 99% versus 96%. And they also detected that asymptomatic recurrence had a better prognosis than the symptomatic, which was 69 months versus 25 months. So these are patients who had both. But what about the recent randomized trial data? This was presented last year in abstract form, which is the French collaborative trial that took 1,775 patients over 7 years and randomized them to either what they called a minimal follow-up, which is history, physical examination, and chest X-ray, or maximal follow-up, which was history, physical examination, chest X-ray, CT chest and abdomen, with contrast and bronchoscopy for some patients. And their primary endpoint was overall survival. So 177 patients were randomized, and they presented these results last year. The primary outcome being overall survival showed that in the control group, the median survival was 8.2 years compared to 10.3 years, but the study did not reach its statistical endpoint. There was a trend towards shorter disease-free survival in the CT group, probably reflecting earlier detection. And the survival rates at 3, 5, and 8 years were not statistically significant. One of their conclusions was that they just need to follow these people up for longer, but I find that difficult to buy, given that by the time they get to 5 years, they're going to be cured of their first cancer if it hasn't come back. So where are we with following up surgically resected lung cancer patients? I thought I would just run through with you what we do in Oxford. So until May 2013, we were entirely chest X-ray follow-up based. And people had a chest X-ray every 3 months for 2 years, and then every 6 months for 2 to 5 years, came to the clinic, had the X-ray on the day. We didn't have the report. It would then be reported. I didn't think that it was a good use of our resources, and I didn't think it was benefiting patients. So we changed our protocol. We introduced initially for 3 years CT at 6 months, 18 months, and 4 years. And over time, we've now gone completely CT-based. So the only time the patient will get a chest X-ray is when they come to that first follow-up appointment at 3 to 6 weeks later. And so these patients now come and have a CT. They don't see us that day, they go home, we get the report, and it's a nurse-led and delivered CT follow-up program, which is telephone virtual clinics. But what does this data show? So we took 466 consecutive patients, which were operated on in our trust, and 331 of them, 71%, have been entered into this CT follow-up program. 16% went and had adjuvant and are followed up by the clinical oncologists who actually scan them less than we do, but that is what it is. 5.8% died before 6 months. We've only lost 9 to follow-up, and 24 chose other follow-up. In that time, we have diagnosed 74 patients with malignancy, which represents just over 20% of them. If you take the patients, those 74 patients, I've divided them here into whether they were program detected or they presented symptomatically despite the program. 60 of them, which was 80%, were program detected, but 14 of them presented symptomatically despite the program. Then divided them into what kind of malignancy did they have. So 16 of the program detected patients were new lung primaries. 36 were recurrence, and 8 were non-lung primaries, because we are doing CT, contrast CT, chest, abdomen, and pelvis. So we've found other primaries in other body cavities. Of the symptomatically presenting patients, 3 were new lung primaries, 6 were recurrence, and 5 were non-lung primaries. You could argue that perhaps I shouldn't include those, but I've included them on the left side, so I thought I should include them on the right. And then if you look at who could have radical treatment, so 15 out of 16 of the new lung primaries were radically treatable. A significant number of the non-lung primaries were, and even some of the recurrence, we were able to give radical treatment to in terms of radiotherapy-based treatments. Whereas only 2 of the patients who presented symptomatically had radical treatment. The median survival for the new primaries is not defined, but it was 44 weeks for the palliative program detected and 23 weeks for the symptomatically despite the program detected. You can see here the difference here in the survival between those groups, which is 92 weeks versus 23 weeks for program and symptomatically detected. Now, this was not a study. This was a change in our practice. So these patients did not have chest x-rays. They had CTs. So we used the Scout, the CT Scout, as a surrogate for the chest x-ray. So of the 60 patients with the program detected cancer, we then used within that cohort of the patients we followed who had normal CTs, we matched them and blinded one of our radiologists to look at all those and try and see on the Scout whether you could see what we'd seen on the CT. And there was significant discordance in 50 of 59 patients with malignancy and 5 of 59 patients with the abnormal CT. There was one patient in whom the Scout image was not suitable for her to look at. And what this shows is a sensitivity of 18% and a negative likelihood ratio for the chest X-ray or the Scout surrogate of 0.9, which means that really the Scout image, if we say it's a surrogate for the chest X-ray, is of no value. What about diagnosis of other conditions? So a number of patients were seen with benign abnormalities, as you would expect, pulmonary nodules, GGO, which we have to date defined as benign, other intrathoracic benign lesions, and because it's abdo-pelvis, some extrathoracic diagnoses as well. Only 2 patients underwent invasive investigation or excision biopsy without any complications. Of course, there are downsides to having the CT. There is the worry for the patient. I don't have any data on that. We haven't collected that as yet. And there is also the risk of radiation exposure. Now, that will be dependent on your protocol. Probably contrast CT, chest, abdomen, and pelvis is the highest dose you could give that. That's about 21 millisieverts, and if you add all that up with all the CTs they're having, it's about 100 millisieverts over 5 years. But you have to remember, these are a group of patients who are at very, very high risk. So the additional risk of the CT in them for other cancers, I think, has to be considered. And as I said, our invasive test rate was low with no complications. So in summary, what do we feel about the CT follow-up of patients who'd undergone resection? Well, patients are at high risk, and the recommendation is that they are followed up. And chest X-ray is probably of no value in these patients. CT can identify recurrence and new primaries at an earlier stage, and there is some evidence that asymptomatic versus symptomatic recurrence has a longer survival. Does CT follow up after your lung cancer surgery and prolong your survival? I think the jury is out. It is unlikely that it's one size fits all. These are people with different stages, different cell types, and over time I think we're just at the infancy of being able to say to a patient with a squamous cell T1A, this is the protocol you should have, not what all lung cancer resected patients should have. There are other benefits of a CT program over and above the imaging modality. It's a single point of contact for survivors. Before, these people saw many, many, many different registrars. probably never the same one twice. It's reduced our requirement to use the clinic. It's an organised clinic. We know before we telephone the patient what the result is, not turn up and see what it shows and then get the report 2 weeks later. So we run virtual clinics. And it has released our registrars. So our registrars no longer see follow-up patients. They see the new patients. And so we're carrying on with CT follow-up. I'd like to thank the rest of our team, particularly the top ones, Fergus Gleeson, Rachel Benamore and Jenny Mitchell, who run this programme with us. Thank you.